Welcome, everyone, and thank you all for joining us. I'm Amir Lefkovich. My day job is overseeing business development activities at Team8 Health, but today I'm going to be the moderator for this event. Before we begin, I'd like to go over a few housekeeping items. If you have any questions throughout the session, feel free to post them in the chat box, and we'll try to get to them during the Q&A session. There'll also be an opportunity to ask the questions yourselves verbally if you'd like during the QA session as well. All right, let's start. Before we dive in, let's quickly go over the agenda for today. We'll begin with brief introductions by our speakers, Professor Varda Shalev, Managing Partner at Team8 Health, and then Deborah DeSanzo, President of BestBuy Health. Varda will then give a general overview about Team8 Health and delve into care at home, its evolution, challenges, and opportunities. After this, Deborah will present the BestBuy Health use case. Varda and Deborah then will conduct a fireside chat where they'll have an open and candid discussion about care at home as well as their own personal experiences. This should really be an insightful discussion. We'll then open the floor to your questions. So to kick things off, let's hear from Varda. Varda?
Thank you, Amir. Hi, everyone. It's a great pleasure being here with all of you and with you, Deborah. I started my journey as a physician specializing in family medicine. I was a family doctor in a kibbutz in 3 small villages, interacted closely with patients, knew their families, their habits, and even made frequent house calls. These visits changed our interactions and relationships going forward. I knew them in a much more intimate way, and it made all the difference. Back then, we documented everything on a paper with a physician's handwriting, so you can guess, nobody could read it. I couldn't even read my own notes. I understood that we wouldn't be able to scale up practicing medicine by continuing to use pen and paper. Indeed, after a few years in the profession, I decided to do a postdoc in medical informatics at Johns Hopkins. While at Johns Hopkins, I started understanding the potential of combining computers and medicine. When I returned to Israel, I founded the first medical informatics department in Israel's second largest HMO, serving 2.5 million patients. And in a very short while, we started capturing digital data for medical records. This was the first digital revolution in medicine, but it was not yet digital health. With time, we started creating health databases of general population, connecting us like never before. In a nutshell, this is who I am, constantly switching hats, sometimes multiple times a day, from seeing patients, founding digital health companies, sitting on the board of Teva Pharmaceuticals, researching and teaching at Tel Aviv University and Harvard Business School with my dear friend, Deborah. And of course, a managing partner at Team8.
Thank you for that introduction, Varda. Seems you were practicing care at home before the rest of industry even caught up. Deborah, now handing it over to you.
Well, hello, everyone. I'm Deborah DeSanzo. So Varda and Team8, thank you so much for having me here. Varda, I loved that introduction. I'm going to steal that. Mine won't be as good as yours, but I love that introduction. So I have been in healthcare technology for an incredibly long time. I started in a startup a long time ago, and my company got bought by Hewlett-Packard. But in that startup, which wasn't a healthcare startup, we actually did a telehealth application. This was 30 years ago. It was a telehealth application, though, that connected the hospitals, the University of Pittsburgh together. And since then, I've built healthcare businesses at Hewlett-Packard, at Philips, at IBM Watson, and now I'm at BestBuy Health. And I like to think that this is the best company ever. This is the best job ever. As Varda said, I also teach at the Harvard School of Public Health, Artificial Intelligence in Health, where Varda comes and helps me, which is such a joy. And I am on the board of AstraZeneca. So that is me.
Great. Thanks, Deborah. Now here again is Varda to talk about how Team8 Health and Care at Home. Varda?
Yeah, thank you. Thank you, Deborah, and thank you, Amir. Team8 Health is a company building fund under the umbrella of Team8 Umbrella, a global venture group that creates and invests in innovative companies. Here are a few things to know about Team8. We work across 4 domains. We started out with cyber, data, and AI, and we developed into fintech, digital health, and venture capital. Since 2014, Team8 has established 8 funds. Overall, 8 funds has raised over $1 billion from 150 esteemed investors. 110 of them are repeat investors. To date, we have built 20 companies from idea to scale. 6 out of them have exited. 2 of them are unicorns, and it truly takes a village. As part of our model, we join forces with hundreds of KOLs from prominent enterprises who form our network, what we call a village, to help us from validation of ideas to product market. HR, business development, tech, legal, and more. We pride ourselves on having access to experienced tech and business talent and our ability to bring them on as founders. You all know the statistics. Most companies fail. So we thought, can we do better than that? Team8 is all about advancing our odds of success. We rethink venture, the model, the process, and above all, the risk. So how do we do it? We explore and ideate around big, impactful problems. We validate our thesis with market expert and our village, and then our team and founders execute. We are building 1 to 2 companies a year, and we invest $5 to $10 million in each company. And here are 5 things to know about Team8 Health. We are proud to have multidisciplinary team. My partners, Asaf Mishari, our cyber and data expert, Dimitrios Kazaukas, our US arm, the former director of Medicare, Dror Grof, our data and ideation expert. We raised $70 million to build 5 to 6 companies, all targeting the US market. We are proud to have significant core investors, including Walmart, Sun Pharma, Medinol, and esteemed family offices. Our very first digital health portfolio company called Fijoya. It's a very interesting, exciting company set to revolutionize the employer-sponsored health sector. We are currently exploring other areas like DCT and VBC, 2 areas where care at home is highly relevant and prominent. So let's talk about care at home. Care at home is not a novel concept. In 1751, the nation's first hospital was founded in Pennsylvania. And it was the beginning of the 19th century where hospitals really began to take off in the US. We are now coming full circle, back home. So what is driving this trend? Firstly, patients are looking for familiarity. We witnessed this trend in other industries before. Just like Airbnb offering a home away from home, an Uber ride that feels like a friendly neighbor giving you a lift in a car. Additionally, the population in the US is aging. Today, more patients demand end-of-life and palliative care services at home. We see that people want to pass away in their own beds. Indeed, deaths at home increased by 1/3 in the last few years and continue to rise. In addition, healthcare system itself is also promoting the care at home model, looking for efficiency, of course. But care at home isn't advancing at the pace that some of us have predicted. At the beginning of 2022, McKinsey estimated that up to 25% of the total cost of care could shift from traditional facilities to the home by 2025. We are not there yet. Yes, we see steady growth, but not the explosion one might expect. So what's preventing care from getting into patients' home? Let's dive in. Like anything in healthcare, care at home was initially hailed as a cost-saving solution. However, the reality is more complex. First, if extensive medical attention is required, costs can skyrocket. Professional caregivers on site and operational overhead can quickly add up. Location matters too. Costs change widely across regions and providers. Home health aid in New York, on average, costs 40% more than in West Virginia. Special devices play also a crucial role, and not every home is equipped to handle them. Think Wi-Fi connection, sterile environments, the space required, and more. But these are not the only barriers. Shifting to care at home requires a true paradigm shift. There are opportunities as well as challenges, and the blanket is always too small to cover all the stakeholders. For healthcare providers, there is a chance to enhance their patients' experience and create new revenue streams and market differentiation. However, providers must also make substantial investments and adjust their operating and economic models. Without payer buy-in, shifting to home-based care won't be feasible. This means not just saving money, but also changing their mindset to focus more on making healthcare easier and more available for patients. New reimbursement structures also pose a challenge. Providing care at home presents unique opportunities for professional caregivers. It can remind them the reason they have chosen to treat patients. It could also potentially allow for more flexibility through telehealth solutions and improved work-life balance. On the other hand, if not done well, care at home could backfire and cause burnout. Just consider the cost of caregiver burnout is estimated at $5 billion annually. 41% of physicians have considered leaving the profession due to work stress and burnout. Will the care at home model increase or decrease the burden and burnout? Additionally, the healthcare industry is dealing with a severe shortage of professional caregivers. From a patient perspective, it's not only about mastering new tech gadgets, it's also about safety and privacy and more. And not all families are willing and able to handle care at home for their loved ones. It's not a one-size-fits-all solution. Moving forward, regulators will need to develop tools to address safety protections and security concerns. It's not enough to give services at home without comprehensive technology, and the technology isn't there yet. One crucial aspect is the lack of integration of care at home solutions. All systems must communicate to allow data interoperability through features like single sign-on, decision support tools, and emerging technologies such as AI and LLMs. Care at home products and services market is highly fragmented. While there is a huge amount of individual point solutions such as dialysis, respiratory, and IV support at home, these solutions lack integration into a unified model. Without a centralized solution, caregivers and patients may find themselves multiple tools, systems, and vendors. This creates silos and inefficiencies. Where are we going from here? Well, The potential benefits of care at home are undeniable, and it's a continuum between wellness at home, inpatient care, monitoring, and caring from distance to full hospital at home. But we are still left with many questions, important questions. Will hospital take the lead, or will other organizations step up? Will every provider have care at home department? Will care at home operation recruit new caregivers or use the inpatient ones? How can we seamlessly integrate primary care physicians into the model? We will need to open our minds to new solutions and a variety of models. I believe, as do many of you, that technology is a key driver. Recent technology advancements have allowed care at home to begin to develop telehealth, remote patient monitoring, wearables, predictive medicine, digital health platform, and more. At the forefront of recent tech breakthroughs is the advancement of LLMs and AI. These innovations have the potential to transform healthcare delivery, especially in home-based care. To talk about this topic, I'm excited to introduce a true expert and pioneer, Deborah DiSanzo, an innovator leader at the intersection of healthcare and technology. As a host lecturer in her Innovation for Physician class at Harvard Business School, and as a personal friend, I am honored to have her with us today. Deborah, the floor is yours.
Barda, that was a fantastic opening for care at home, and I absolutely agree with all of the challenges that we have. So I think I'm going to go through and talk about how BestBuy Health sees care at home, and maybe actually, talk about why BestBuy is even in this. Why is BestBuy in health? So we start with, this is our strategy on a page. And our strategy really is to enable care at home for everyone. If you think about it, well, there's a lot of retailers in healthcare, and a lot of the retailers are doing important things. They have pharmacies, they have clinics, they have primary care. That's not Best Buy. Best Buy is a consumer electronics retailer with an amazing logistics capability, with Geek Squad, who is trusted to go into people's homes to help with their care. And all of that we consider enabling care at home for everyone. Across this continuum, Varda, you just said it, from wellness at home to aging at home to care at home. And we think about this really in those three pillars. So at wellness at home, for example, we think that Best Buy can offer a unique and perhaps better experience to people who are looking for digital health. So of course, we are very proud that we merchandise on bestbuy.com and at Best Buy Oura Rings, but there are additional products for sleep, for monitoring, for hearing, for baby care, and even continuous glucose monitors for people who would like the experience of buying their continuous glucose monitors and other digital health devices at home. And all of these, we put a small service around. So for hearing aids, for example, you can go into a Best Buy Health store, you can get a hearing assessment if you are a candidate for an over-the-counter hearing aid. You can see those at Best Buy. And if you need more than an over-the-counter hearing aid, we have a partner that will direct you to for prescription hearing aids. Aging at home is really where Best Buy Health started, and it's all about ensuring that people who want to live independently and age independently at home have the devices and services that are going to keep them healthy and safe. This is a prescription model, and we do everything really from loneliness support to urgent response to Lyft rides to nurse on call to health coaches to caring plans. And then finally, care at home, which really came in the pandemic. What was happening in the pandemic is, first of all, we didn't have enough beds. And in fact, of January of this year, with the triple influenza, RSV, and COVID pandemics hitting all at once, we didn't have beds again. And so in the pandemic, Centers for Medicaid and Medicare announced the hospital at home program, provided a method for it to get paid for, and creative hospitals started doing hospital at home. This is what they found. Someone had to get all the remote patient monitoring devices together. Someone needed to decide that they worked. Someone needed to connect them to a home hub and make sure that they worked in the home. And then somebody had to ensure that all of those devices were connected to the electronic health record back at the health system. In the pandemic at the beginning, that someone fell on the backs of the nurses and the physicians that didn't have time to do it. So, but BestBuy can do it. So this is really enabling care at home, where BestBuy takes care of the technology, takes care of the logistics, takes care of getting everything that you need into the home when it needs to be in the home, and then everything out of the home when it needs to go out as well. So this is our strategy: enable care at home for everyone, built on really BestBuy's core competencies. We are really having some initial very good success. In the next slide, we see that Geisinger actually is using our system not for traditional hospital at home, but for their chronic disease management program called Connected Care 365. What happens is Geisinger, a physician, enrolls a patient in Connected Care 365. The order goes to Geek Squad. Geek Squad gets the equipment together that is needed for that particular patient, and it brings the equipment to the patient's home. Of course, it's scheduled, brings the equipment to the patient's home and trains the patient and their family, just as you see here, on how to use the equipment. And then ensures that, as Varda said, the Wi-Fi is working, the equipment is connected, the equipment can connect back to Geisinger's electronic health record. We did this, we piloted this for a year before we launched it system-wide at Geisinger, and this is what we found. For patients who were able to use Geek Squad, we had a faster time to activation, a 19% improvement in patient adherence, a 20% improvement in patient net promoter scores of patients who are on the Connected Care 365 program, and we reduced the alert burden for the caregivers. Varda, this is what you were talking about. Is this more work for caregivers or less? Now, Geisinger is one of our clients. We have partnerships with 25 health systems now: Advocate Health, the third largest healthcare system; Mass General Brigham, in my backyard here in Boston; Common Spirit, UPMC, Memorial Sloan Kettering, UC Davis, and more. We go to the next slide. I'm just going to show you our vision of how we want this to play out in the next 3 to 5 years. So this is Abigail. Abigail is a 75-year-old woman who is diagnosed with congestive heart failure. Her daughter wants her to be well, and we can take Abigail's journey to the next slide. Her daughter wants her to stay well, and so she goes to BestBuy and gets blood pressure cuff, a scale for her. But she wants a little bit more support than that. So she signs Abigail up for BestBuy Health Social Care Services, which helps Abigail make sure she's weighing herself, make sure she knows how to use her blood pressure cuff, and checks in with her every month to see how she's going. I think the slide probably builds, so consumer wellness, and then go to social care. The next thing is Abigail is out in her yard. She feels chest pain. She presses the button on her device to get urgent response. She talks to urgent response, and they dispatch emergency medical services. Abigail's taken to her local hospital. She's a cancer candidate for hospital at home. Geek Squad meets her and her daughter at her home, gets all of the equipment set up, makes sure it's working, coordinates other logistics, because it's not only the monitoring devices that have to go in hospital at home. We need to make sure the nurse visits are facilitated. We need to make sure that the physician visits are facilitated. We need to make sure that infusions, medications, other devices get into the home when they need to be there. Abigail does well on hospital at home. She moves into chronic condition management for the next 6 months. She does very well on chronic condition management. And finally, she is discharged, but not discharged without ongoing support. She can continue to get that ongoing wellness support from the 1,000 caring center agents that we have across the US who are supporting people like Abigail and her daughter. And Varda, you were saying, what do people think about care at home? This came from one of the patients at NYU Langone Hospital at Home program. And this is why we are so passionate about care at home and hospital at home. This is what she said: home where I could easily shower, home where I could sleep in my own bed, home where I could eat my own food, where my grandsons could visit, where my family could visit without looking for parking, where only my germs were, where I didn't share a room, where I could water my plant, and where I could collect my mail. We are seeing all across our hospital at home programs that patients are healing better. They're healing better where they're surrounded by the people and things that they love. And so we are extremely encouraged by the first 2 years of hospital at home and by many more years of aging at home and wellness at home. And we look forward to what the future will bring. Varda, back to you. I think we do our fireside chat now.
Actually, before Varda, I'll start that and kick it off. Thanks, Varda and Deborah, for sharing your insights and experiences with us. Super interesting. Now let's start the fireside chat. I'd like to kick things off with posing a question to the both of you to get things going. In your experience, how do you get conservative health organizations, for example, hospital systems, to prioritize and invest resources in innovation? Who wants to take this one first?
You know, it's a key question because in every organizations, most of the people are happy as they are, you know, and to find the one that really wants a change, it's not easy to find. It's not connected to the role of the patient. It's connected to the personality of the patient. So I think Deborah, I'd love to hear what you say, but I'm always looking for the one that is, you can really, he's the change person, you know, he's really leading the change. By the way, I enjoyed very much your talk, and you know, it was very inspiring to see that most of the problems that I raised, you are solving already. But it
But
made
it is very hard. I look forward, I think we're gonna
Yeah,
talk
and also,
about
you know, when you solve something, you always create a new problem. That's what
Yes,
we
right,
always feel.
right.
And I feel like I ask myself, okay, so as a family physician, how am I a part of this model? Do the patient actually leave me in his, you know, worst hours that he needs me more? How am I part of the model? Did you
Yeah.
take decisions?
Yeah. So I think to Amir's first question, so we did find very much, I mean, CMS has approved 2,000 hospital at home beds. And we know all of the health systems that have started to engage in hospital at home, and they really are the innovators. They are the innovators. They are Mass General Brigham. They are Advocate. They are Common Spirit. They are UPMC. They are Geisinger. They are what we always think of I want to actually put UMass in there as well, who is a very much smaller system, but known to be an innovator, UPMC. So we start with the innovators, but then there was in the pandemic, and there is still really this need We went in January from, and I won't say the hospital name, but two of our health systems went from having 30 hospital at home beds running every day to over a weekend 75. And that was simply because there were not beds to put the patients in. And so how hospital at home runs is you either need to be admitted to the emergency department, where an emergency physician will look at you and determine if you are a candidate for hospital at home or not. Or you're in a bed and somebody says, okay, this patient actually is in this bed, but that patient may do better at hospital at home. So you are essentially then instead put in a bed that is in your home. Now, at that point, it is absolutely the physician's decision. And how do you get that physician to make the decision? So you start with an innovative health system that says, we don't want to build $1.2 billion towers anymore. We're going to open this hospital at home program. But then it comes down to a decision from the physician that's seeing that patient. And I think we want to leave it that way, right? Because some patients in the first 2 years of hospital at home, we have seen very good results in these programs. But the patients have been selected from the physicians because some patients are going to do well at home and perhaps some patients will not do well at home. So we do want to leave it in the physician's hands. And I think it's just as everything. As physicians see it working, they get more experience of knowing who it works for, who it doesn't work well for, and then it will grow.
Of course, and you were talking about innovative organizations, but within the organizations, whom are you aiming to talk to? Is it the CMO, it's the CFO, the CEO?
Yep,
Who you
yep.
start?
The chief, and where the care at home programs fall under. So in Common Spirit, for example, it falls under the chief nursing officer.
Hmm.
And in Mass General, that Mass General has put all of their home assets together under the home program. In Advocate, it falls under a special hospital at home program. So who reports up directly to the CEO. So whoever is running the hospital at home program, that's who we seek out in this case.
Yeah, I think that's a challenge in digital health because I see here the cyber. As I told you before, we started with cyber. And in cyber, you have the CISO. You always approach the CISO and you have the
Yes,
someone. And here we have to find who is
yes,
the...
that is very true. That is very true. You do have to find who is, and in some health systems, there is nobody because this is new. It only started in the pandemic. The waiver, which pays for this, is set to expire at the end of this year. We're all thinking that it will get extended. And we really hope it does get extended because the hospitals just still do not have enough beds. And it's not like all of a sudden we're going to have more beds.
And by the way, were you surprised from something in this project? Because when I start a project, always I find something very surprising. The opposite way that I was thinking before. So I have many examples.
Yes, I'm going to be very transparent with you. So, of course, with everything, you start with typically smaller health systems, smaller problems, smaller numbers of patients. You might start with a system that's doing 10. And we had that down pretty much. It was the logistics on that are more complicated for a hospital than they are for BestBuy, but the logistics for having 10 patients running a day was fairly simple to handle. And then all of a sudden, we started going with bigger systems. And then we found out how difficult the logistics really were. We thought we had a thought about this. We thought, yeah, logistics, we've got this. But as soon as we got our first full 30 patients per day, we found out that the kits weren't where we thought they were supposed to be. So we had assigned a particular number of kits to this healthcare system that we could take back, clean, send back out to patients. And then the kits weren't where we thought they were, in somebody's trunk. They were on somebody's doorstep. They were not, the health systems are not Best Buy. You can't control the inventory as tightly as we control it at Best Buy. You know, so what we found is that, to get this working right, we're actually going to put the Geek Squad agents in a trailer on the hospital facility until we can get the whole logistics going. And that's what we did. Then we got it going. And then we start our next, then we start with somebody doing 60, and we find that the logistics are certainly doubled. And every health system, of course, does it a little differently. So you find out you have to, what you did for one doesn't work for everyone. And you really have to put all of your know-how into supply chain, logistics, technology platforms to make everything work better. Yeah.
Wow, that's a ride. By the way, do you find time to teach every year? Because, you know, this year I decided not to teach at Tel Aviv University because I didn't have the time. How do you find the time, you know?
So I block out,
I hope you will continue because
yes, Harvard School of Public Health. I teach this program once a year. It is, they have a cohort of 30 mid-career physicians who are going to get essentially an MBA for healthcare. They are mid-career physicians who are going to lead health systems or lead health businesses across the country. And I just love teaching it. It's only 3 weeks. So it's 3 weeks, it's 15 classes, 1 class every day. It goes really fast. It's a lot for the students. It's a lot for me, but I love it because I get so much energy from it. And because I'm teaching artificial intelligence in health, and this will now be my 5th year teaching it. The first year I taught it, when I came in, the students thought I was somehow evil because they did not want to talk about artificial intelligence. But now, of course, everybody wants to learn about AI and how it can help. And so it just gives me a lot of energy.
Yes, of course. Amir, I see that there are so many questions from the audience, so we're willing to answer.
Okay, so let's dive into that. Thanks so much for that really informative discussion. Gives us a lot to think about. And as you said, we see so many incredible questions in the chat box. We'll hope to get to all of them, but we'll see if time allots. What I'm seeing is that we're seeing a theme around caregivers' involvement at care at home. How's Best Buy engaging family caregivers in your care at home model, from program onboarding to capabilities in a patient-centered app? How proactive are these programs and follow-ups? And how much are they able to incorporate family members in the care plan? And so Deborah, if you can address that, and Varda, if you had experience how to engage caregivers, that'd be great to hear as well.
Family caregivers are extremely important. First of all, in the aging at home solutions, which I didn't talk that much about, but in the aging at home solutions, it typically comes from a daughter or a son who wants to ensure that their mother or father can age independently at home. So the caregiver is very involved in what devices, what solutions get in place for their parents. Sometimes the parents aren't that interested in their daughters and sons helping, but the daughters and sons are very helping. And when, for example, part of that service is in some cases paid for under Medicaid and Medicare. And in those cases, Geek Squad will take a device out and ensure that the device also comes across the threshold and ensures that there's connectivity to make sure that the device works, and trains everybody on the use of the device and what it connects to. In the hospital at home program, both this is a benefit, and I've also heard of it as people are worried about it in hospital home. Will family caregivers, will too much fall on their shoulders? We do ensure that we train the family caregivers also on how to use the technology, because whoever needs the technology likely is going to need help. So we ensure that a family member is there, that they also get trained, that they know who to call, they know how to connect to the command center or urgent response if they need it. So the family caregivers are very important, and all the family caregivers are involved in all of the care plans as well. So I think that answers the question.
Yeah, I agree. I think that the patient and the family is the most unused resource within the system of medicine. And we need more hands and more brains. We just have to explain more and to get them with us to the process. And it looks like you are doing it. Amir?
Yes, sorry about that. Another question was around, Bart, I think you mentioned interoperability early in the presentation. Both of you, do you have any thoughts on how healthcare ecosystem can challenge that of system and device interoperability? How do you address the issue of data silos that are being created?
So, data operability is my second name. That's what I do for so many years. Each time that we think that we got it, we see that it's still so far because you have different coding systems. And also even with Fire and HL7, we still are having a lot of challenges. We have the system, but it doesn't work always perfectly. So it's a mandatory issue that we have to solve in order the system not to do too many doubles and triples on the same issues and mistakes, of course. And I think I see it as a process that is continuous. We'll never finish doing it. It's here to stay. It becomes better and better, but still you always want to connect another thing. It's very important to connect it to the electronic patient record because those patients are sometimes at home, but sometimes they go to other physicians, and we have to see the full picture. I must say that in Israel, it's a lot easier because we have only 4 funds, and we connected all the hospitals and the funds and the patients. But when I see the American system, it's a lot more difficult. Deborah, do you have something to add?
It's so frustrating. So our model is we have a home hub and we connect the devices to the home hub. The home hub's used for collecting of the vital signs as well as two-way communication between the physician and the nurses and the patients. And the home hub connects to the electronic health record. Connecting to the electronic health record now to Epic and Oracle is relatively easy. Connecting to the devices in the home, I'm so frustrated. It's still, after all of these years, I have been working on this for like 25 years. We've had so many, standards bodies trying to work on this, but still the data coming off of these devices is all different, even if they purport to comply with the standard, the way they comport to the standard, they're all different. It's serving no one. And it takes an incredible amount of engineering time to interface to these devices. And it's serving no one. And it's quite frankly, just driving up the cost of monitoring, which doesn't need to be. Yeah.
And what about authentication? Knowing that the patient is taking the blood pressure and not somebody else, and in which context he's taking
Yes,
the blood pressure.
so it's very interesting. So not every blood pressure cuff is the same. They're not so easy to use. Some of them don't work as well on elderly people. And so, and we start to find out some of the scales don't work, and we start to find this out too. And, we and our health system partners see which ones are working and which ones aren't. And then we are BestBuy, we don't make any of we have a home hub, we don't make any of the devices that hang off the hub, but it is, our health system partners are seeing which devices are working better now. And I can only hope too that they continue to make the devices work better, easier for patients, and also interoperate better. Yeah.
Thank you. Amir.
Yeah, I think that was a theme in some of the questions. How are you engaging with the medical device manufacturers to work on integrated solutions across the continuum? How does that look like? And, I'm going to put a few questions in one question because there's just so many questions. And do you only work with providers? Like, what's the business model? How do you guys operate in the ecosystem? Where do you fit in and who do you work with?
So that was really in the strategy on my first page. I said we enable care at home for everyone, and we build it on Best Buy's strengths of being an omni-channel consumer electronics retailer. So we have already relationships with, who you think of as the remote patient monitoring companies, the companies Withings, Omron, the companies who are making these devices. And we try to, I'll use Dexcom. Dexcom is, as you know, a CGM. So Dexcom, we integrate Dexcom into the home hub for Best Buy Health for hospital at home. But we also make Dexcoms available on bestbuy.com and in Best Buy stores, so that patients who want to buy their CGMs and their follow-up supplies that they need can also buy them at Best Buy. And it's an easy way to purchase. And we put, there's a HIPAA compliant platform there. There is, a way, a connection to a pharmacy, a connection to a prescriber. So it's a little service put all together so that you can get your CGM. But we try to do that, tie not only, it's not simply merchandised at Best Buy on bestbuy.com, it also ties into the home hub for hospital at home. On the business model question, so hospital at home is by CMS a provider program. And so we work with providers there are, however, programs for aging at home that are paid for also under Medicaid and Medicare, also health insurers. So health insurers pay for some of those services. But actually, in our enabled care at home model, 1/2 of all of our solutions are self-paid by consumers. And I think in the future, we can't let go of this. Health systems are under pressure. Insurers, are also under pressure. And so we have a model where there are family caregivers who want to provide services for their parents to age independently at home, and those are all self-paid.
Great. Well, thank you so much. Varda, I have a question for you, and Deborah, please join in if you're looking to invest in anything. They're asking about what aspects of care at home excites you as an investor and company builder, and what opportunities do you see in the shift from hospital to home?
So as I said in my talk, there are a lot, but when we at Team8 are looking for a company, we are looking for more product than service. So we're looking to build a product that will help the system, and it has to deal a lot with data, sometimes with cyber, with fintech. So actually, we love what's good for us is an infrastructure for a health problem. So we're looking for a big problem, and hospital at home is really a challenge, because I believe, like the patient that you told us about, that people want to be at home, and it's better for them to be at home. Also medically, it's better. Not talking about depression and things like that. So I think we'll have this trend, it will continue. We are looking for an infrastructure that and we are going to invest in infrastructures for home. It can be the interoperability issues, it can be the data cleaning, it can be decision support systems, integrating of systems within home. Those are the areas that we are looking deeply at. And of course, looking all the time at the value that you create. So I think we have to measure ourselves because, you know, I remember ourselves in the HMO that I was working. We created a hub of monitoring at home. And one of the problems, and Deborah, maybe you will elaborate more about it, is the false positives of continuous monitoring. Because if you monitor all the time, then you have a lot of false positives. And sometimes it costs a lot of money to the organizations. So we had to take off and to say, okay, we are not continuing because it was the opposite way that we expected. We hospitalized more than before. So now we have better AI and we know how to be a lot more precise. And I think we have to really look at the value that we create and to measure it. And then we can convince, by the way, other systems to adapt it and not to stay with out of pocket money.
Yeah, I mean this really is a very good AI problem. You know, when monitoring started out, then everyone said we want all of the data, put all of that data in the electronic health record, but really nobody wants all of that data because it's too much data. And most of the time there's absolutely nothing on that data that you need to see. And so then the concept came, okay, we only need to see when there is, you know, something that we need to see. So only record that. But then what you really want is the combination of vital signs and the prediction of when an adverse event is going to happen. And so that is absolutely where AI comes in. And I think that what we're seeing interestingly is the algorithms that work in hospital for prediction of adverse events are not working the same way in the home. So, and you know, there's lots of reasons for that. So this is another great AI model to get enough data of enough diverse patients to be able to really create AI models that are going to enable the prediction of an adverse event. And that's really the data that you want. And you want that to prevent false alarms either way. You know, you don't want an alarm going off when it's a false alarm. You also don't want an alarm going off too often, right? So this is a very good data in AI, but which is not solved yet. There's simply not enough data in the home monitoring, available data in the home monitoring market yet to make good models, but we will develop those. Yeah.
So who's collecting the data? Do you use the data in
Yeah. So we I learned from IBM, BestBuy Health owns no data. We do not own the data. We transmit, we collect the data from the devices that's integrated into the home hub. And from there, it goes into the hospital's electronic health record. However, we also run for some of our clients, about half of them, a clinical command center. And in the clinical command center, we still don't own the data, but of course, we use algorithms and we watch the monitoring data to know if something is happening with the patient or to predict an adverse event, right? Yes. So, but all of the data that's collected from our system, we don't own it. We don't even store it for a long time. It goes into the electronic health record.
And usually the organizations are the ones to develop the algorithms?
We are for, yes, and part of our joint development, so we have joint development partnerships with Advocate Health and Mass General Brigham, and part of the development is also to develop those algorithms.
Sure. Wonderful. I think we have time. That's a super interesting discussion. It's kind of a mini fireside chat between the two of you. That was great. We have one more question, time for one more question. I'm gonna kind of change it a bit. There's a number of questions around pharmaceuticals, how do they play a part in this role? And also, does Best Buy Health support clinical trial operations? Or are you getting involved in that area at all?
That was another, and Var, you'll talk from Teva's point of view too, but this was another big pandemic thing, that clinical trials at home, and what we have found in clinical trials at home with remote patient monitoring, that yes, also just like Geisinger, the patients are more compliant. They stay on the programs longer when they don't have to go, when they can be monitored at home. And so I think most pharmaceutical companies are now doing clinical trials at home. Where we are finding really a lot of interest is in immuno-oncology. So CAR T patients not having to spend 14 days in the hospital, but enable them to go home with monitoring, and also in oncology clinical trials where it's sometimes a burden for the patient to get into their health system. It might be farther than their typical health system is. We're finding it's very advantageous for patients to do that. Yeah.
Yeah, I agree. And also, we are looking always in pharmaceutical companies for diversity of patients first. And we can find them at home better because it's not the same patients in rural areas. And also, it's easier for them. It's more comfortable for patients to come to a central place, etc. So,
Yeah.
and I think the adherence of those patients is also higher. So
Yes.
we
Yes.
lose them with the time. It's also.
Yeah.
Well,
But we had our last question. We just have 2 minutes. We just have 2 minutes left, but I wanted to get this question in, Amir, if it's all right.
yeah, of
So,
course.
Barta, you have been doing this for a very long time. Data, AI, integration, digital health. It has not been there have not been too many women who are in this space. So, what's it been like? And how do we continue to grow everybody's career, but also women's careers in digital health?
Great questions. First, it's the two of us, right? So 2 out of 2.
Yeah.
I think that's what connects us, so well during those years. But I see more and more women in health and more and more women in technology. So I'm very optimistic on one hand. I have always a few women that I mentor in digital health. And I think we can influence the market. For example, I had a physician now for a half a year that twice a week she was used to come to Team8 with us. And she told me, I got an offer to manage innovation in one of the district of an HMO. So I have 2 offers, one to be a deputy and want to be the manager, the CEO. And I feel that, I have to learn, to still learn. So I told her, take the CEO, I will help you. Okay, so we have to help women to do it faster like men, not to feel that they have to digest too long. And we have to continue teaching and continue being in boards. And when we are there, we influence. That's what I think. And it's getting better all the time. We see more and more.
That's
Great.
right. I agree.
Wonderful. Wow, that went really quickly. Unfortunately, that's all the time we have. I want to extend special thanks to all of you for taking the time to join us today. We truly appreciate it. And thank you so much to Varda and Deborah for sharing your insights and experiences as well. Please be on the lookout for our next webinar in the coming months. We'll let you know about it when we get closer to it. If you're interested in learning more about Team8 Health or BestBuy Health, please feel free to reach to us at the contact information you see on the screen. Thanks again. Take care and have a great day, everyone.
Thank
Deborah,
you.
many thanks. It was really a pleasure.
Also, Varda, thank you so much. Thank you for inviting me, and thank you, Team8. Really, the hour went by so fast. I hope it did for the audience as well. All right. Bye-bye, everyone.
Thank you.
Bye.
Bye-bye.